Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss about thyroid gland. So we all know thyroid secrete three hormones. These three hormones are T3, T4 and not TSH. TSH is secreted by pituitary, we already covered. Third hormone is calcitonin. T3 and T4 are secreted by follicular cells of the thyroid gland, whereas calcitonin is secreted by parafollicular cells or C cells. And from the name you can remember, calcitonin, it is related to calcium. Calci means calcium. So we will study this along with other drugs which are used for affecting calcium. That means the drugs used in osteoporosis. So here we will limit our discussion to mainly thyroid hormones, that means T3 and T4. Now important thing, what is the basic difference between T3 and T4? The basic difference is T3, it is the more active hormone. Main active hormone is T3, whereas T4 is less active. But T4 is long acting, whereas T3 is relatively short acting. So based on these differences, which hormone will you like to use if a person has hypothyroidism? If a person has low thyroid hormone, obviously we need to replace these hormones. So which hormone will you prefer, T3 or T4? Yes, we will prefer T4. The question is why? The reason, it is long acting. So we need to give less frequently. We can give once a day. So T4 is a drug of choice for hypothyroidism due to any reason. And the drug T4 is available as the name as L-thyroxine, whereas T3 is available as liothyronine. So T4 is L-thyroxine and T3 is liothyronine. So L-thyroxine is a drug of choice for hypothyroidism. Okay. But where we will use liothyronine then? When everywhere we have to use L-thyroxine, in which case will you like to use liothyronine? Yes, it is more active hormone. So it can be used in emergencies. So liothyronine, it is used in case of emergency hypothyroidism. Emergency hypothyroidism is called as, yes, mixed edema, coma. So the only indication of liothyronine is mixed edema, coma. But remember, even for mixed edema, coma, the drug of choice is L-thyroxine. So L-thyroxine is a drug of choice for every hypothyroidism case. Only thing is liothyronine can be used in mixed edema, coma. Again, it is not the drug of choice. Okay. So just like every hormone, this is mainly the replacement therapy. We have less hormone, so we give from outside. Hypothyroidism is there, we give thyroid hormone from outside. Now coming to the second major problem in thyroid gland, it is hyperthyroidism. If a person has elevated levels of thyroid hormones, then what we will do? So for that, first we need to know how thyroid hormones are synthesized, how they work. Then we will want to decrease their action. So for understanding the drugs used in hyperthyroidism, first we will try to understand how thyroid hormones are produced and how they work. Okay. So this is a thyroid follicle. It contains follicular cells. Follicular cell. This is blood. These are peripheral tissues like liver, muscle, adipose tissue. These are. First question is, which mineral is present in thyroid hormone? Thyroid hormone contains iodine. So first of all, there must be some mechanism to uptake the iodine, to trap the iodine. And that mechanism is, there is presence of a pump in the follicular cells. The pump is known as sodium iodide symporter. Sim means same direction, shortly known as NIS, sodium iodide symporter. It helps in uptake of sodium and iodide inside the follicular cells. So with the help of this symporter, the iodide enters in the follicular cell first. But the thyroid hormones are synthesized inside the colloid. So this is the colloid area. This is the colloid area. So thyroid hormones are synthesized inside the colloid. So iodine must go there. So after entry inside the follicular cell, the iodide is transported inside the colloid. Okay. Now in the colloid, iodide is converted to thyroid hormones T3 and T4. One enzyme works which is called as thyroid peroxidase. So thyroid peroxidase converts iodide to T3 and T4. Now how this is produced? There are several steps involved. So how iodide is converted? First of all, this iodide, if you see, it is inorganic. It is inactive. So first of all, we need to activate it. This cannot combine with other things. We need to activate it. So for activation, we need to oxidize this. The first step which occurs is iodide is oxidized to form a free radical. Iodide free radical. The step is known as oxidation. And it is catalyzed by the enzyme thyroid peroxidase. Remember, all the steps in the colloid are done by thyroid peroxidase. So iodine has become active now. Now, although it has become active, but still it is inorganic, whereas thyroid hormones are organic compounds. So we need to convert it into organic compound. But how? So it's simply by attaching to some organic compound. Clear? So inside the colloid, there is presence of tyrosine molecules. Thyroglobulin protein is there, which contain tyrosine molecules attached. So iodine attaches to those tyrosine molecules, so it become organic. So this step is known as organification of iodine. Organification simply means iodine will combine with the tyrosine molecules. So if one iodine combines to tyrosine molecule, it is called as monoiodotyrosine or MIT. And if two iodine attaches, it will become diiodotyrosine DIT. In a normal person, there is sufficient amount of iodine. So there is no problem in the iodine. So mostly two iodine attaches. So it becomes DIT. So normally DIT produced is more than MIT. Okay. Now after the formation of MIT and DIT, they are getting bored. So what they do? They start forming couples. So they will start combining with each other, start forming couples. So that reaction is known as coupling reaction. Coupling reaction. So if MIT combine with DIT. MIT means one iodine, DIT means two iodine. So that will form three iodine. So a compound known as T3. If DIT combine with DIT, 2 plus 2, 4. So that will form T4. So formation of thyroid hormones T3 and T4, it is done by coupling reaction. Okay. Now both these organification as well as coupling reaction are also catalyzed by a thyroid peroxidase enzyme. So basically thyroid peroxidase carry out three reactions: oxidation of iodine, organification and coupling, finally resulting in formation of T3 and T4. Okay. So after formation, this T3 and T4, they are stored in the colloid. So they remain stored in the colloid for a long time. Now whenever TSH comes from the anterior pituitary, it will stimulate the thyroid gland to secrete its hormones. The hormones T3 and T4, they are binding to thyroglobulin protein still. So what TSH do is, it will help to release them from the thyroglobulin, and this T3 and T4 now will come into the blood. So T3 and T4 will come into the blood. But the first question is, which hormone produced will be more, T3 or T4? Yes, it will be T4, because we discussed normally DIT produced is more. So when there is plenty of DIT in coupling reactions, mostly T4 will be produced because DIT will combine with the DIT. So normally T4 is much more than T3. But which is the more active hormone, T3 or T4? Yes, it is T3. So T3 produced is very less, T4 produced is large. But problem is T4 is not that active. Main active hormone is T3. So we want T3, but we have got T4. So what will happen? So now this T4, it will go into the peripheral tissues. Peripheral tissues like liver, muscle, adipose tissue. And in these tissues, T4 will be converted to T3. T4 will be converted to T3. This is known as peripheral conversion. The name says in the peripheral organs T4 is converted to T3. Okay. Before going further, first we need to know what is this T3, what is this T4, what is the meaning of 3, what is the meaning of 4. Yes, it is obviously iodine. But what is the full form? Where these iodines are attached? What are those 3 positions? What are those 4 positions? So if you see, the full name of T3 is 3, 5, 3 prime triiodothyronine. Whereas T4 is 3, 5, 3 prime, 5 prime tetraiodothyronine. So what we note is T3 contains 3 iodine, 3, 5 and 3 prime position, and T4 at 4 positions, 3, 5, 3 prime and 5 prime positions. Now if you want to understand the structure activity relationship, try to understand that if the iodine atom attaches to positions where prime is not present, that means at 3 or at 5 position, it increases the hormone activity. But when iodine attaches to prime positions, the hormone activity decreases. Okay? So if you note, in case of T4, 2 activity increasing substances and 2 places where activity is decreasing. So that's why activity is very less. On the other hand, in T3, 2 are increasing and only 1 is decreasing. So activity is more. So T3 is more active than T4. Okay? So if we want to convert T4 to T3, so obviously we need to remove one iodine. So the enzyme which removes the iodine is deiodinase. Deiodinase. But from which position we want to remove the iodine? Yes, we want to remove the iodine from the 5 prime position. So if we remove 5 prime position, then it becomes 3, 5, 3 prime. Clear? So the enzyme involved here is called as 5 prime deiodinase. 5 prime deiodinase. So that will help in peripheral conversion. Okay. But there is another enzyme which removes the iodine from 5 position. So the enzyme called as 5-deiodinase. So what will happen if 5-deiodinase work? So it will remove iodine from 5 position. So what will be left? So it will form 3 prime, 5 prime triiodothyronine. So if you see this 3 prime, 5 prime deiodinase, so 3, that means 1 is increasing the activity, whereas 2 substances are decreasing the activity. So this is totally inactive form of thyroid hormone, and this is known as reverse T3. Reverse T3. So reverse T3 is totally inactive. T3 is highly active, T4 is less active, reverse T3 is totally inactive. So if 5-deiodinase work, it form reverse T3. But if 5 prime deiodinase work, it result in formation of T3. Okay? So in peripheral conversion, T4 is converted to T3, enzyme is 5 prime deiodinase. Okay? So now we have got the active hormone. Now it will work and produce the action. Okay. Now what we want to do in hyperthyroidism? First of all, how a patient of hyperthyroidism present? In hyperthyroidism, the major symptom will be, there will be heat intolerance. Remember, thyroid hormones are metabolically active hormone. They increase the energy production. So person will have too much heat generation. So person will develop heat intolerance. Second, because metabolism increases, there will be weight loss. So weight loss, heat intolerance. And third and the most important feature are sympathetic features. So person will develop tachycardia, palpitation, hypertension. So all these symptoms will occur. Clear? So characteristic features of hyperthyroidism: weight loss, heat intolerance and sympathetic symptoms. So we want to treat hyperthyroidism. So what are the options we have? We want to decrease the hormone activity. So what are the options we have? The options are, right in the beginning, we will want to inhibit the entry of iodine. If iodine do not enter, hormone will not be produced. So we can give NIS inhibitor, sodium iodide synthetase inhibitors. Second thing we can do is we can inhibit this enzyme thyroid peroxidase so that hormone is not produced. If T3, T4 are not produced, they will not work. Third, we can inhibit the secretion of hormone. If hormone is produced but it do not come to blood, it cannot produce action. So secretion inhibitors we can use. Then we can inhibit peripheral conversion. Peripheral conversion. If hormone is not activated, again activity will decrease. Yeah? And then we have two more group of drugs. One which will destroy the thyroid gland. If gland is destroyed, hormone will not be produced. And lastly, which are the drugs used for symptomatic treatment. So we will discuss these drugs in hyperthyroidism. First we will enumerate. First we have NIS inhibitors. Second we have thyroid peroxidase inhibitors. Third we have secretion inhibitors. Then we have peripheral conversion inhibitors, thyroid destroying drug, and lastly we have drugs for symptomatic control, or we can say adjuvant drugs. So we'll discuss these one by one, starting with NIS inhibitors. So iodide, it enters through sodium iodide same portal. So if we inhibit that, iodine will not enter, so hormone will not be produced. And the drugs which inhibit NIS, these include perchlorate, pertectinate, and thiocyanate. These drugs are highly toxic to be used clinically. So these drugs are not used clinically, only the theoretical drugs are there. Investigational drugs are there. But important thing to remember, these substances, they are present in large quantities in certain foods like cabbage. So if a person consume large quantity of such foods, there will be decrease in iodine in that person, entry of iodine in that person, decrease in formation of thyroid hormone. So that person may develop hypothyroidism, that person may develop goiter. So these foods are known as goitrogens. So NIS inhibitors are not important for treatment of hyperthyroidism, but rather they are important that the foods containing these substances can produce goiter. So those foods are called goitrogens. Okay, so this is the first mechanism, but we do not use clinically. But second mechanism, which is very important and we use very commonly, are called as thyroid peroxidase inhibitors. Thyroid peroxidase inhibitors. And the drugs in this group are carbimazole, methimazole, and propyl thiouracil. All these three drugs, chemically they belong to same category, and that chemical structure is called as thioamides. So all of these are thioamides. They may be carbimazole or methimazole like, they may be propyl thiouracil like. Now why we have written two drugs on one side and second drug on another side? The reason being, carbimazole and methimazole, they are quite similar drugs. Carbimazole is metabolized to form methimazole and then produce the action. So final effect will be same. Carbimazole is a prodrug. It is converted to methimazole, then action occurs. Propyl thiouracil is slightly different. And the differences between these two, you can easily remember from the name. Propyl thiouracil name contains P. So there are many P's which are less in propyl thiouracil. Number one, it is less potent, whereas carbimazole is more potent. So propyl thiouracil need to be given in high doses, whereas carbimazole or methimazole in lower doses. Second, propyl thiouracil has less plasma half-life, means short acting, so it needs to be given 3 times a day, whereas carbimazole and methimazole are long acting, can be given once a day. And third, it has less transfer across placenta. Propyl thiouracil crosses the placenta less, whereas carbimazole and methimazole can cross more. So because it crosses the placenta less, so it is preferred in first trimester of pregnancy. Propyl thiouracil is a drug of choice in first trimester of pregnancy, and from the name you can remember, propyl thiouracil is commonly written as PTU. Propyl thiouracil, it says पहले ट्राइमेस्टर में यूज करते हैं. okay? तो प्रोपाइल थायोयूरासिल इट इज यूज्ड इन फर्स्ट ट्राइमेस्टर, पहले ट्राइमेस्टर में यूज करते हैं. बट all three drugs, carbimazole, methimazole, propyl thiouracil, they can cross the placenta. PTU has less chance, others have more chance. So if they cross the placenta, the baby may develop some congenital malformations, and very commonly the MCQ asked which congenital malformations are seen, and most importantly you need to remember choanal atresia. So these drugs can cause choanal atresia if we use them in pregnancy. All three drugs. PTU less chance, other two have more chances. So PTU is preferred in first trimester of pregnancy. Then lastly, PTU can inhibit the peripheral conversion also, means it has two mechanisms. It not only inhibit the thyroid peroxidase but also inhibit 5'-deiodinase enzyme. But carbimazole, methimazole do not have any such property. Okay. Now, if we come to important points, that carbimazole and methimazole, they are more potent and they are longer acting. So, in most cases of hyperthyroidism, we prefer these drugs. The only place where we prefer propyl thiouracil is first trimester of pregnancy. Routinely, we prefer carbimazole or methimazole, but in first trimester, we prefer propyl thiouracil. In second and third trimester also, carbimazole or methimazole are preferred. So if we talk about hyperthyroidism in pregnancy, the drug of choice for hyperthyroidism in pregnancy, in first trimester, the drug of choice is propyl thiouracil. In second and third trimester, it is carbimazole or methimazole. Remember, these two are indistinguishable. Any of them can be used. But important question, if in the exam they ask what is a drug of choice for hyperthyroidism in pregnancy, they do not specify the trimester. If they specify, it is easy, we have discussed. If they do not specify the trimester, then I will advise you to mark propyl thiouracil. The reason being, one, it may be the old question where differentiation was not there in the trimesters. We always say in PTU should be given in pregnancy and carbimazole, methimazole should not be given in pregnancy. But now we know that carbimazole, methimazole are used in second, third trimester. So the question may be old because they have not mentioned the trimester. But second thing, suppose the trimester they know the difference, still they have asked what is drug of choice in pregnancy. Still I will ask you to mark propyl thiouracil because it is the least teratogenic among the three. So if they are asking about pregnancy, we will mark the least teratogenic drug. Okay. So drug of choice, if they do not mention the trimester, I will advise the propyl thiouracil. Okay. So these are the important points regarding the thioamides. But suppose a patient comes to us with hyperthyroidism, the characteristic feature of hyperthyroidism, weight loss, person is having heat intolerance, and person is having sympathetic manifestations like tachycardia, palpitation, tremors, all these are present. This person presents to our office, hospital. So what we will do? First, we will want to confirm it is hyperthyroidism. So we will do investigations. What investigations? Yes, thyroid profile, that means T3, T4, TSH levels. The most important in these is TSH. Remember, T3 and T4 level will change according to TSH. So what will be the TSH level in hyperthyroidism? It will be lower because T3, T4 are high and that will suppress TSH. So TSH decreases. Okay? So even if T3, T4 is normal, if TSH is suppressed, it means hyperthyroidism. Okay? So TSH level is low. So what we will do? We will start the drug of choice. So we will start carbimazole or methimazole. Suppose we start the 10 milligram carbimazole. Yeah. So we ask the person to take carbimazole for a week and come back after 1 week. So after 1 week, the person returns and he says that, Doctor Saab, koi fayda nahi hua. There is no improvement. All symptoms are as such. So what we do? Normally, if the drug do not respond, what we do is we increase the dose. So we make it 20 milligram. We increase the dose and ask the person to take for 1 week. So person goes to home, start taking 20 milligram, and next week also person comes with the same complaints that there is no improvement. All symptoms are as such. So we again measure the T3, T4, TSH. Still the symptoms are they are deranged. TSH is low, T3, T4 are high. So what we think? We think that even this dose is not working. So we increase the dose further. So we make it 30 milligram. Ask the person to take for 1 week. Next week again person comes. This time agitated that koi dawai de do dhang ki. It's not working. So now we again measure the T3, T4, TSH. Still the levels are deranged. So what we thought, that it is also not working. So we tell this person, so we are increasing the dose last time. If still it do not work, then we will change the drug. So we start the 4 times dose, 40 milligram. Next week, person do not come. 4 people bring the person on shoulders. The person has gone into severe hypothyroidism. The question is why? Why the drug was not working earlier? Now suddenly the person has gone into hypothyroidism. Why this happened? The reason is a normal person has stores of thyroid hormones. This T3 and T4 formation is stopped, but release it not. Okay? So normal person has a store for around 1-2 weeks. In hyperthyroidism, it will be even for longer time. It may be 3-4 weeks. Okay? So if a person is already having large amount of stores, we give drug which inhibit the formation of thyroid hormones, it will not produce effect, it will not manifest itself, because the hormone which is already stored, that will be released. So we are not stopping the release. So that means this hormone can be released which is already stored. So the effect will come when this release stops. Or we can say when the hormone which is already present, that finishes, and that will take a time of around 3 to 4 weeks. So the take home message is, we need not increase the dose every week or every few days. So we need to wait for minimum 3 to 4 weeks. If still the effect is not coming, then we need to change the dose. So in simple language, the thioamides, or we can say thyroid peroxidase inhibitors, are very slow acting. So we need to change the dose after 3 to 4 weeks. So we cannot expect the effect immediately. So their effect will come in 3 to 4 weeks. Okay. So this is the second group of drug we can use in hyperthyroidism, thyroid peroxidase inhibitors. Okay. So now we'll move to the third drug, secretion inhibitor. The drug which inhibit the secretion, they include sodium iodide, potassium iodide, and Lugol's iodine. So what these drugs do, they inhibit the secretion of thyroid hormone. Maybe the hormone is produced in plenty, but that hormone cannot come in blood. So when it is not able to come to blood, it cannot produce action. So we need not wait for 4 weeks. Immediately the action will come. So these are the fastest acting anti-thyroid drugs. So fastest acting anti-thyroid drugs are secretion inhibitors, iodide, sodium iodide, potassium iodide, Lugol's iodine. Okay. Another use of these drugs is they are given before surgery, pre-operatively. So person has large goiter. So we want to operate and remove the thyroid gland. But because of goiter, because of enlargement of gland, the blood supply will also increase. So when we give iodides, they will immediately shrink the gland. The gland will become firm. So when it is firm, it is shrunken, the blood supply will also decrease. So the surgery will become easy. Okay? So iodides, they are given pre-operatively because of 3 reasons. They make the gland firm, small, and less vascular, so that surgery become easy. Okay. So this is secretion inhibitor. Then lastly, number 4 drug, we can give 5' deiodinase inhibitors, peripheral conversion inhibitor, number 4 drug, or we can simply say they inhibit the enzyme 5' deiodinase. And you can remember from the name peripheral conversion P. So all these drugs start from P. These are propranolol, which is a beta blocker, propyl thiouracil, which we already discussed, and prednisolone, which is a steroid. So all these drugs, they can inhibit the peripheral conversion of T4 to T3. Okay. Then moving to number 5 drug, which is called as thyroid destroying drug. Now what happened? Just now we discussed that if the goiter is large, what we can do is we can remove the thyroid gland. Suppose we want to do surgery, we want to remove the thyroid gland, but the surgery is risky. Like the person is very old, person is of 85 years, 90 years old person. The surgery is risky in this. Plus this person has some heart disease, person has atrial fibrillation. Surgery is even more risky. So we do not want to take that risk. So we want that the same function of surgery can be done by some drug. So we want that thyroid gland can be destroyed selectively so that hormone production decreases. So thinking about this, physiology, what we discussed, we discovered a drug called as radioactive iodine or iodine 131. What is the normal isotope of iodine? Yes, it is 127, but iodine 131 is radioactive. Okay? So radioactive iodine, important thing to remember, it behaves like normal iodine, just like normal iodine. Like normal iodine, it is taken orally. Like normal iodine, it is taken up by NIS, sodium iodide sympathetic. So it goes to thyroid gland. Like normal iodine, it goes into the colloid. Like normal iodine, thyroid peroxidase work and it is converted to T3, T4. So this stored T3 and T4, now it contains radioactive iodine. So when it is stored for longer period, now this radiation activity will start. So it will start destroying the thyroid gland. So that's why radioactive iodine calls as thyroid destroying drug. So it will destroy the thyroid gland. So hormone production will decrease. So hyperthyroidism can be controlled. Okay. The question is, normally we have studied so many drugs, but we do not discuss about radioactive drugs. Why we do not use radioactive substances normally? Because जो radiation वो निकालते हैं उस पे किसी का नाम नहीं लिखा. That means they are non-selective. The radiations can destroy anything. So when the radiations can destroy anything, so why we can use radioactive iodine but not other radioactive substances? So there are three reasons. Number one, radioactive iodine is selectively taken up by thyroid gland because NIS will take it to thyroid gland only. So there is very low chance that it will go to other organs. So only in thyroid it works. Number two, in the thyroid where it is stored, it is stored in the center of the colloid. If you see, it is stored in the center of the follicle. So whatever radiations are emitted, they will be limited to thyroid gland. Suppose if a drug is stored here in the follicle, then the radiations can go outside also. So it is stored in the center, so radiations are limited to that organ. And third and most important thing is, it mainly releases beta rays. These beta rays have low penetrating power, so that means they cannot go long distances. So they mainly affect the thyroid gland only. So we can use radioactive iodine but not other radioactive substances because of three reasons. One, they are stored mainly in colloid. Number two, they are stored in the center of the thyroid gland, so only thyroid is affected. And third, they emit the low penetrating radiations like beta rays. Okay, but like every radioactive substance, radioactive iodine is also contraindicated in pregnancy. Okay. Contraindicated in pregnancy. Now suppose we take a situation, a person is given overdose of carbimazole or any antithyroid drug, person develop hypothyroidism. So how to treat this hypothyroidism? Simply stop the drug. If we stop the drug, body can form thyroid hormone again. That means most of the antithyroid drugs, they cause reversible hypothyroidism. That means whenever we stop the drug, the hormone production will again start. Suppose you give overdose of radioactive iodine. Can it cause hypothyroidism? Obviously yes, hypothyroidism can occur. Okay? Now you stop radioactive iodine, will it recover? Answer is no, because the gland has been destroyed. Who will form thyroid hormones? So it will cause irreversible hypothyroidism. Irreversible hypothyroidism. That is the main problem. Permanent hypothyroidism will occur, so it will require lifelong hormone replacement therapy. So we need to give lifelong L-thyroxine to this person. So obviously we will not want to give unnecessary lifelong hypothyroidism for very long periods to a person. So this drug is avoided in young patients. So it is absolutely contraindicated in patient below 35 years of age. That does not mean that whenever the person is of 36, start this. It means that it is avoided in young patients. Higher the age, the better the indication. Clear? So radioactive iodine, two important things, contraindicated in pregnancy and young patients. And one more question which is asked commonly, what is the half-life of radioactive iodine? Half-life of radioactive iodine is 8 days. What is important to remember is not 8, it is days. Because the question is commonly asked, what is the half-life of radioactive iodine? The options given are 8 hours, 8 days, 8 weeks, 8 months. Yeah, so you need to remember around a week, 8 days. Okay, so that is important about radioactive iodine. Then moving to the last group of drugs in the hyperthyroidism, adjuvant drugs or symptomatic drugs. Suppose a person comes to you with severe hyperthyroidism. What is emergency severe hyperthyroidism known as? Yes, thyroid storm. Thyroid storm. So what will be the features of thyroid storm? Emergency hyperthyroidism. Remember, same 3 features: heat intolerance, weight loss, and sympathetic symptoms. But it is an emergency. So which will be most dangerous? Weight loss? Not too much. Heat intolerance? Not too much. But the third is the problem: sympathetic symptoms. So this person of thyroid storm may develop severe sympathetic symptoms like extreme tachycardia that may lead to fibrillations. The person may develop arrhythmias. The person may develop severe hypertension. So all these are life endangering things. So the most important thing in a patient of thyroid storm is to first save the life. And how to save the life? By stopping the sympathetic symptoms. And which sympathetic receptor is present on heart? Yes, beta receptor. So the beta blockers, they are drug of choice for thyroid storm. They are life-saving drugs, and the drug we use is propranolol. Propranolol, it is a drug of choice for thyroid storm because it is the life-saving drug. It will save all the sympathetic symptoms and the person can prevent from dying. That is very important. Okay? Apart from this, it will also inhibit the peripheral conversion of T4 to T3. So this is drug of choice. But it will not affect the thyroid hormone as much. So for affecting the thyroid hormone, controlling the thyroid hormone, we use the drug called as propylthiouracil. So read very carefully. If they ask the question, what is the anti-thyroid drug of choice? That means to control the level of thyroid hormones, it is propylthiouracil. Overall drug of choice is propranolol because it is life-saving. But obviously in emergency conditions, we use several drugs together. So if the question asked drug of choice, it is propranolol. Life-saving drug, propranolol. But if they ask anti-thyroid drug of choice in thyroid storm, it is propylthiouracil. Okay, so these are the important points regarding the thyroid gland. Thank you.